Having finished all the microcytic hypochromic anemias, let us start with macrocytic anemia. Now, under macrocytic, there's a very famous mnemonic, which is famous amongst the boys, at least for obvious reasons, and that is Lady Hardin Medical College, LHMC. So, what are all the macrocytic anemias that we have? First and foremost, it is associated with liver diseases. Next, it is associated in a case of hypothyroidism. So, we get to see macrocytic anemia as well over there. Then there's another cause of cytotoxic drugs or chemotherapy drugs that also can result in macrocytic anemia. And lastly, the one that is going to be the showstopper and the most important, which we have to study in detail, and that is megaloblastic anemia. This is megaloblastic anemia. So repeating, when I'm saying LHMC, we have liver diseases, hypothyroidism, megaloblastic and cytotoxic drugs. As I said, we are going to study megaloblastic anemia in a lot of detail. What is megaloblastic anemia? It is the deficiency of vitamin B12 and folic acid. Do you remember what were the sites of absorption so that I can start from the absorption again? Vitamin B12 is absorbed from the terminal ileum, and folic acid is going to be absorbed from the jejunum. Very, very, very important, right? So let me start off with the more important one, that is vitamin B12 deficiency. Before that, I have to tell you vitamin B12 absorption. That is again going to be more important. So can you tell me, as I just asked you, what is the site? It is the site being not just the ileum, but the last part of the ileum, that is the terminal ileum. The next question that is asked, what is absorbed? What form of vitamin B12 is absorbed? Is vitamin B12 going to be absorbed as it is from the food? No. Till the time vitamin B12 doesn't come with IF. What is IF? IF means intrinsic factor. So till the time vitamin B12 doesn't come with intrinsic factor, my ileum will not absorb it. It's a condition. Ileum has kept a condition that if you come with intrinsic factor, I will absorb you, otherwise I will not. So intrinsic factor is also referred to as the Castle's factor. It is also referred to as the Castle's factor. And where does this factor come from? Who is releasing this factor? This factor is being released by the parietal cells of the stomach. This factor is being released by the parietal cells that are present in the stomach. So as simple as that, I need to absorb vitamin B12, my stomach has to do some work, my stomach has to make intrinsic factor. So let me draw one diagram for you all. For example, this is the food and this is the vitamin B12 that you have consumed, and which is the food item which is very poor in vitamin B12, coming back and writing that also. So remember, vegetarian food by definition is deficient in vitamin B12. So usually you will see that people who come to you with vitamin B12 deficiencies are pure vegetarians. So remember, vegetarian food is deficient in vitamin B12. Very, very important information. Okay, on that note, let's move forward. Here you have some food item where there is vitamin B12, but B12 is stuck in this food item. As this B12 will go, as the food is going to go over here, the first thing that you will do is separate the B12. How is B12 released from the food items? B12 is released from the food by the enzymes in the stomach, by the peptic enzymes. By the peptic enzymes, it is going to get released from the food. So now I can say that fine, because of the action of the peptic enzyme, the B12 is free from the food. What is it going to bind to next? B12 is going to bind to haptocorin. B12 is going to bind to haptocorin. So you will ask me, where does haptocorin actually come from? Haptocorin is going to be a salivary gland product. Haptocorin is something that is released from the salivary gland. So you will actually realize in this entire pathway, now this process happens. It is that, so now this time, like in iron, I told you a lot of relationships happening in sideroblastic iron deficiency. Here also I will tell you a lot of relationships happening. But यहाँ पर बहुत interesting story है. यहाँ पर the relationship is that when you are in some place, you are not having a relationship there. That time you are only friends with a person. When you go to another place, then you will have a relationship with that person. Means haptocorin was released where? Haptocorin was released by the salivary gland in the mouth. But did B12 and haptocorin have a relationship there? No. Where did they have a relationship? When they went to a new organ. When they went to the stomach, then they had a relationship. So now vitamin B12 and haptocorin have had a relationship in the stomach, but haptocorin was actually released in the salivary glands. Now when they move forward, we realize that when they enter into the duodenum or when they enter into the intestine, now we will see that the haptocorin will be released. How is the haptocorrin going to be released? So haptocorrin will be released by the pancreatic enzymes. It will be released by the pancreatic enzymes. So now haptocorrin se ho gaya breakup. Now the B12 will combine with whom? Now the B12, listen to me very, very carefully. Now the B12 will say, I have to enter into a relationship, and that relationship will be intrinsic factor. Guys, where does intrinsic factor come from? Dekho, wahi story na. Intrinsic factor actually got released in the stomach, but did B12 enter into a relationship with intrinsic factor into the stomach? No. It entered into a relationship when it went into the duodenum and the ileum. So remember, intrinsic factor actually comes from the parietal cells of the stomach. Parietal cells of the stomach, but B12 will combine with it in the next wala organ. So simple. Haptocorrin was released by the salivary gland, but haptocorrin and B12 combined later on when they went through the stomach. Same way, intrinsic factor was released in the stomach, but this combination happened when it went into the duodenum. So finally, the B12 and intrinsic factor have made a complex, and are they going to be absorbed from the ileum? Yes. So please remember, the terminal ileum, the terminal or the distal ileum has certain receptors called tubulin receptors. This is known as tubulin receptors, and to that finally your vitamin B12 and intrinsic factor will bind. Vitamin B12 intrinsic factor will bind to the tubulin receptors that are present in the terminal ileum, and finally your the B12 will be absorbed. But B12 is only absorbed once the B12 is absorbed. Once it has been absorbed, everyone needs a travel buddy. Like remember, for iron we had a travel buddy called transferrin. For B12, what is the travel buddy that we have? We have transcobalamin 2. We have transcobalamin 2, which is the travel buddy, and it is going to take it to whatever tissues and whatever uses I need to do of vitamin B12, which will help in it. So trans word always tells me trans for transport, cobalamin for vitamin B12. If it would have been transferrin, then transport of ferrin, transport of iron, transcobalamin, transport of vitamin B12. So now you will ask me that what are the uses? Why and where all am I going to use vitamin B12? So please remember, vitamin B12 is needed for the nuclear synthesis or the nuclear maturation. Why? Because you know that vitamin B12 is needed in the thymidine production. DUMP, DTMP, remember that pathway in biochemistry? So vitamin B12 is basically needed for the thymidine production. Now because of this thymidine production, the nucleus will mature. And if I'm saying that if a patient is B12 deficient, this means the nuclear maturation is not going to happen. If a patient is B12 deficient, the nuclear maturation will not happen, but only the nucleus is being targeted. The cytoplasm not being targeted. The cytoplasmic maturation shall remain as it is. Cytoplasmic maturation shall remain as it is. So this basically means that there are two people, they are of the same age. Both of them are say 20 years old. One of them has gained maturity as for a 20-year-old. One of them has not. They are in the same environment, they are living together, studying together, everything about them is the same, but one of them has become mature and one of them has not. So why? Because now I will call it nuclear cytoplasmic asynchrony. This condition is referred to as the nuclear to cytoplasmic asynchrony, which means that both of them have not matured in the same process. The nucleus has not undergone a maturation and the cytoplasm has undergone a maturation. And why has the nucleus not undergone a maturation? Because vitamin B12 is not available, and if B12 is not available, nucleus will not mature. This was one use of vitamin B12. Now coming to the other use, we all must have heard about this pathway in our biochemistry cycle. What is vitamin B12 needed for? Vitamin B12 is needed for the conversion of methyl malonyl coenzyme A to succinyl coenzyme A, and in that process also homocysteine changing to methionine. Now please note, if vitamin B12 is not available and these steps do not occur, methyl malonyl coenzyme A will not change into succinyl coenzyme A. So that basically means that succinyl coenzyme A was very, very essential. Ab wo nahi banega. Methyl malonyl coenzyme A levels will keep on increasing and they will never ever change into succinyl coenzyme A. You know what was succinyl coenzyme A needed for? It was needed for myelin production. Succinyl coenzyme A was needed for myelin production. So this means now the myelin production is not going to occur and therefore the patient has neurological neurological symptoms. Why does the patient have neurological symptoms? Because B12 was needed for the production of succinyl coenzyme A. Now, succinyl coenzyme A will not form, myelin production will not occur, neurological signs and symptoms shall occur over here. Same way, homocysteine had to change to methionine. That is not going to happen again. This means homocysteine levels are very, very high and methionine levels are very, very low now in this patient. Do you know high levels of homocysteine has been associated with what? High levels of homocysteine have now been associated with atherosclerosis. So that's quite a weird thing. How an anemia can have high homocysteine and lead to atherosclerosis if it worsens. These are the two outcomes. So I've told you 3 outcomes of B12 deficiency. Firstly, B12 was needed for nuclear maturation. So if there is no B12, there is no nuclear maturation, there is nuclear cytoplasmic asynchrony. Point number 1. Second, it was needed for succinyl coenzyme A. Succinyl coenzyme A nahi banega. This means patient is going to have myelin problem, neurological problem. Thirdly, when homocysteine will increase, this is going to result in atherosclerosis. So all your pathogenesis is done. Now can we understand why will the patient have vitamin B12 deficiency? Simple. Vitamin B12 deficiency, someone who is on a vegetarian, pure vegetarian diet, because I just told you vitamin B12 is deficient in a vegetarian diet. Next, someone has an increased demand. That increased demand could be pregnancy, lactation, growing child, any reason for an increased demand. Infection. Can you recall from your basic microbiology, parasitology, which infection results in vitamin B12 deficiency? That is Diphyllobothrium latum or D latum. D latum or Diphyllobothrium latum causes B12 deficiency. So guys, tell me 2 things. There is one infection that is known for causing iron deficiency anemia, and that infection is the hookworm. And there is one infection known for causing megaloblastic anemia, and that is going to be D latum. Please. And what is the other name for D latum? Do you remember? D latum is known as the fish tapeworm. D latum is known as the fish tapeworm. Go to your parasitology section in microbio. I have taught you this over there as well. Coming to the next. Now I said that for the absorption of vitamin B12, what all do you know? What all do you need? Number 1, I need ileum, terminal ileum. So if there is any ileal disorder, vitamin B12 will not be absorbed. Secondly, if I have any kind of malabsorption in the ileum, B12 will not be absorbed. For the absorption of B12, what was the other factor I needed? Intrinsic factor. Intrinsic factor nahi bana. For example, the patient had undergone a gastrectomy. If intrinsic factor is not there, then again B12 will not get absorbed. Pancreas, were pancreas also helping in separating the haptocorin wala steps? If there's a pancreatic problem, then also B12 absorption will not occur. And finally, pernicious anemia. What is pernicious anemia? That is something we can focus on. All the others are common sense, na? Gastrectomy, ileal diseases, pancreatic diseases, demand, diet, infections. Yes. Now I come down to pernicious anemia. What is it about pernicious anemia? I think by now all of us know. Pernicious anemia comes to fall under an autoimmune disorder. Pernicious anemia comes to fall under an autoimmune disorder, and this antibodies are present against in 3 types. Actually, we say there are 3 types of antibodies that can cause pernicious anemia. Please listen to this very, very carefully. So when I say type 1, there is going to be a problem in binding of B12 and intrinsic factor. B12 and intrinsic factor will not bind. So there is some antibody which will not let B12 and intrinsic factor bind to each other. In type 2, B12 and intrinsic factor have bound to each other, but they will not be allowed to bind to what? They will not be allowed to bind to the ileal cubulin receptors. So remember, B12 and intrinsic factor together, they have made a group, but the antibody is not allowing that group to get absorbed. And finally, the type 3 is when there are antibodies against parietal cells. Parietal cells were releasing what? Intrinsic factor. If there are antibodies against it, intrinsic factor will not be released only. And again, B12 deficiency. So what is pernicious anemia? Pernicious anemia can have 3 types of antibodies. Either the antibody will not allow B12 and intrinsic factor to bind, or the antibody will not allow B12 intrinsic factor to bind to the receptor, or the antibody will not allow the parietal cells only to release intrinsic factor. That is what results in pernicious anemia, and that wraps up all of your causes of vitamin B12 deficiency. What are you ready for next? The clinical features. What all does a patient present with? Any patient of anemia will come to you with tiredness, fatigue and pallor. That is going to be a part of any kind of anemia. Then what you see additionally is a very important finding which has been given in a lot of exams, is associated with B12 deficiency, that is the hyperpigmentation. There is a hyperpigmentation usually seen in the knuckles and the interphalangeal areas. The knuckles and the interphalangeal areas tend to show you hyperpigmentation. Then, especially something that you see with B12 deficiency is atrophic glossitis, the tongue. You have these papilla on the tongue, they all become smoothened out. There is atrophic glossitis, and that is what you call as the beefy red tongue. You call that as the beefy red tongue. And finally, if you are dealing with a case of pernicious anemia wala B12 deficiency, pernicious anemia was what? Antibodies were present against the parietal cells. Someone is coming and attacking the parietal cells, imagine. So if the parietal cells are damaged, the stomach will become smooth. What is that known as? That is known as atrophic gastritis. The stomach is becoming smooth. Why? Because antibodies are coming and attacking the parietal cells of the stomach. Atrophic gastritis, is this a risk factor for gastric adenocarcinoma? Have you studied the same concept way back in your GIT chapter? Yes. So repeating once again, please note, when I'm dealing with clinical features, fatigue, pallor, every anemia shows. Hyperpigmentation of knuckles, very, 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 very important. How many times should I add that very? You can add it on your own. Very, very, very important. This picture is for B12 deficiency. The tongue is also very smooth. The stomach is also very smooth. Atrophic glossitis, atrophic gastritis. Remember these for B12 deficiency. But something that we are missing out on, and what is that? Specially seen with B12 deficiency only and not seen with folic acid deficiency. What is that sign and symptom? Not seen with folic acid, but seen with B12 deficiency are the neurological manifestations. When we talk about the neurological manifestations, these patients suffer from something known as SACD. Can you help me with what is SACD? It is subacute combined degeneration. It is subacute combined degeneration. So that means what? Acute, not exactly chronic. Short term, middle miss, subacute. Degeneration, because there is usually degeneration of the spinal cord tracts. The spinal cord tracts are going to be degenerated. So tracts of the spinal cord, like the posterolateral tracts, they are degenerated. So degeneration samajh aa gaya. Why was neurological manifestation happening? Remember that pathway of how succinyl coenzyme nahi ban paya, how methyl malonyl did not convert into succinyl, myelin did not form. So you know why neurological pathway occurs. Why are you calling it combined? Because these patients tend to present with sensory loss also and motor loss also. So the reason for calling it combined is a combination of sensory as well as motor loss. Very, very, very important. I hope we all have understood the basic pathogenesis, because we are now ready for the RBC indices. Means hemoglobin, for obvious reasons, will be less because it's an anemia. But I am interested in what is happening to MCV, MCH and MCHC. Repeating MCV, MCH and MCHC. So MCV will be more, because what kind of an anemia is this? This is a macrocytic anemia. Do you remember what was the normal MCV? The normal MCV was 80 to 100 femtoliters. So basically over here the MCV shall be more than 100 femtoliters. Even the MCH tends to be raised. It looks as if, because of the surface area, it looks as if the MCH is raised, and the MCHC comes out to be normal. Repeating, there is an increase in MCV and MCH, and the MCHC comes out to be normal. That is the RBC indices profile of megaloblastic anemia, because now you will have to know the blood picture. Blood picture includes not only problems in the red blood cells, but also in the white blood cells. Yes, very, very important, because nuclear cytoplasmic asynchrony. Nuclear cytoplasmic asynchrony will not just affect the red blood cells, that will affect all the cells of the body. So all the lineages are going to get affected. What are the things that you see in red blood cells? Let us see and then come back and make a list. The first thing that you notice is, look at these normal cells that I've got for you. But now look at what are the cells over here. Compare the size. Has the size become bigger and no pallor? They are all full. So can I say because MCV was more and MCH was more, these are all the macrocytic cells that I'm seeing of megaloblastic anemia. Not only macrocyte, not only am I seeing macrocytes, some of them are also becoming as a long oval, big and long. So I also call them macro-ovalocyte. So there are two things that I see in this picture. First and foremost, I notice macrocyte. Second, I notice macro-ovalocyte. What next? Look at the next picture, the third finding. The third finding is that I see these single dots. What are these single dots? These are known as the Howell-Jolly bodies. These are referred to as the Howell-Jolly bodies. First and foremost, if you are asked the appearance, these are single dots that are present. I've learned a very simple mnemonic. Do you remember in the previous segment of this chapter, we have studied something called Pappenheimer bodies, and Pappenheimer bodies were too many. How will I learn that Pappenheimer bodies are too many and Howell-Jolly bodies are single? So देखो अभी exam time है. Exam time पे you are happier being single. I'm happy and jolly to be single. After the exam time, you will not want to be single, but अभी के लिए because of concentration, you are happy and jolly to be single. So this Howell-Jolly body is happy and jolly to be single. It's a single dot. Your next question will be, what is it composed of? What is the composition? These dots are nothing but DNA or nuclear remnants. These dots are nothing but DNA or nuclear remnants. And finally, where are they seen? Of course, I can see that. Which anemia am I talking about? They are seen in megaloblastic anemia. But what is the next question? Where else do you see them? They are seen in a case of post-splenectomy. That is when the spleen has been removed. You know, this is a very, 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 very important question. So many times in HEMAT, I keep going very, 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 because I know those are like sure short questions of your exam. So repeating once again, I have a case of megaloblastic anemia. I will see Howell-Jolly bodies. I have a case of post-splenectomy. After the spleen is removed, they will say, what are the findings you see in the blood? Howell-Jolly bodies. This was finding number 3. What all have I done? Finding number 1, macrocyte. Finding number 2, macro-ovalocyte. Finding number 3, Howell-Jolly bodies. Finding number 4 is referred to as the Cabot rings. What is the shape that you see? I see a beautiful figure of 8, and that's the mistake that students do. They believe it is only going to be figure of 8. No, you know, it's a very thin thread. That thread, if I take a thread, I can fold the thread in any round, B, D, any kind of direction. The location, it can be any kind of direction. So it can be figure of 8, B, D, anything. So what is it composed of? What is the composition? It's just a single thread. It's a mitotic spindle. Remember, it is an arginine-rich mitotic spindle. So it's rich in one very important amino acid, that is arginine, but ultimately it's an arginine-rich mitotic spindle. Now, let me tell you, in pathology, arginine se related 2 questions. One arginine-rich question that you have is to do with Cabot ring. The second, they will ask you, in which kind of killing mechanism do you use arginine? Arginine is needed for nets. And in biochemistry, they will ask you, arginine is the precursor of which mediator, and that is nitric oxide. These are your arginine questions which are important for the exam. Repeating, it is needed for the production of nitric oxide, it is needed for the killing in nets, and it is made up of, or it is going to make up the Cabot rings. We are not done. The 4th one. Now we come to the 5th finding. So many findings, and this finding is known as basophilic stippling. Firstly, basophilic stippling is made up of RNA. I'll be talking about all these inclusions in the end also. But basophilic stippling is also this dot that you're seeing over here. This basophilic stippling is also noted. So coming back, what all did you see in the RBCs? First, I saw big cells called macrocytes. Then those big cells got a little oval, so I saw macro-ovalocyte. Then I saw single body, happy and jolly to be single, so those were Howell-Jolly bodies. Then I saw the figure of 8 appearance, and that was the Cabot ring. And finally, I saw the basophilic stippling. These were all problems that I saw in a case of red blood cell. But I told you that you will also see problems in white blood cell, and that white blood cell problem is a hypersegmented neutrophil. You know that it is very, very important. So what am I writing? Hypersegmented neutrophil. Please note that how many lobes does a normal neutrophil have? I have taught you in the WBC chapter. A normal neutrophil has 3 to 5 lobes. So it's going to look something like this. So for example, this is how a neutrophil looks. 3 lobes or chalo 4 lobes. Chalega. So basically a normal neutrophil has 3 to 5 lobes. When do I call it hypersegmented? There are 2 criteria. Either of the 2 criteria you can fulfill. Either 5% of the neutrophils have 5 lobes. 5% of the neutrophils have 5 lobes. So you counted 100 neutrophils. Out of that you said, ma'am, after counting 100 neutrophils, I found 5 neutrophils which had 5 lobes. So I say, yeah, that's hypersegmented. Or even if you find any one neutrophil with 6 or more than 6 lobes. So let me see what is the picture given over here. I see 1, 2, 3, 4, 5, 6, 7. I see 7 lobes over here. Do I need to count more? No. Even if I see one neutrophil with 6 or more than 6 lobes, ho gaya. That is a hypersegmented neutrophil. That is what I see in a case of megaloblastic anemia. So that is going to be my WBC finding. It is a hypersegmented neutrophil, which is very, very important. But now please note that because, listen to this very carefully, because there was a nuclear cytoplasmic asynchrony, ultimately whatever is forming is not correct. Can I say that no matter whatever is forming, it is ineffective production because nothing is being formed correctly? It is ineffective production. So can these patients in the long run land up with something known as pancytopenia? Yes. So many a times pancytopenia is what? Pancytopenia means RBC, WBC, platelet, all the counts are low. Why are the RBC, WBC and platelet all counts low? Because there is a nuclear cytoplasmic asynchrony. The entire nuclear morphology has gone for a toss. So this patient or this anemia can very commonly present with pancytopenia. Now, because I'm talking about the bone marrow, let me go into the bone marrow. What will I see in the bone marrow? Firstly, you're saying, ma'am, outside though we are a total mess. No cell is doing proper work. There is ineffective production. This means my bone marrow will have to do a lot of work now to compensate. The bone marrow is hypercellular, but can you tell me which aspect of bone marrow is trying to compensate more? The RBC, the WBC or the platelet? Of course, anemia hai, so RBCs are going to compensate more. So that means that out of this hyperplasia that I'm talking about, it is primarily going to be erythroid hyperplasia that I shall find. Primarily, erythroid hyperplasia will be noted. So now I'm going to tell you one ratio. Every bone marrow that you have, every bone marrow has a ratio known as ME ratio. What is ME ratio? How many myeloid WBC wale cells are there? And how many erythroid cells are there? Myeloid to erythroid ratio is calculated, and that ranges for usually, the normal is usually, it's a long range actually. If you go in actual pathology, read books, then it is everywhere between 2:1 to 15:1. That is how it ranges. From 2:1, it can go to 15:1. I don't want you to learn all of that. Beech ka kuch yaad rakh lo, 2:1, 3:1 if you learn, that is good enough. If you learn 2:1 or 3:1, that is enough. Basically, erythroid come hai. But now I am saying that erythroid hyperplasia has occurred. If erythroid hyperplasia has occurred, is this going to become reversed? So this was the normal, but now the denominator will become more. Can I say there is reversal of the ME ratio? And that is the sentence that I was watching out for. This megaloblastic anemia shows you the reversal of ME ratio. And this means lots and lots of erythroid cells. Please remember, for the higher institute exams, these erythroid cells show you a sieve-like chromatin. These erythroid cells show you a sieve-like chromatin. So these look like a sieve-like chromatin. Only this sentence, you don't need to know any picture, but this is important for the higher institute exams. Those are your bone marrow findings. We are done with the indices, done with the peripheral smear, done with the bone marrow. Now we are left with the biochemical findings. So tell me something. If in the end of the day, no matter how much production you may be doing, if at the end of the day there is ineffective erythropoiesis and it's not actually the right type of cells you're producing, means all of them are going to break. If all of them will break, all the red blood cells will break, the LDH and the bilirubin will increase. Of course, if there is ineffective erythropoiesis and lysis will occur, then LDH and bilirubin will increase. Common sense, vitamin B12 and folic acid का तो deficiency है, that is obviously going to be decreased. What has happened to homocysteine? Do you remember homocysteine was not, देखो vitamin B12 is not there. Will homocysteine convert to methionine? No, so homocysteine levels will increase. Will methyl malonyl coenzyme A convert to succinyl coenzyme A? No. So methyl malonyl coenzyme A levels will increase. And if the patient has, what if he or she is a case of pernicious anemia, will that person end up showing you intrinsic factor antibodies? Yes, that's the entire biochemical profile that you have for megaloblastic anemia. Repeating, serum bilirubin is more and LDH is more because there is ineffective erythropoiesis, cells are breaking. B12 and folic acid का तो deficiency ही है. Homocysteine and methyl malonyl coenzyme A are released and intrinsic factor antibodies are there if the patient is suffering from a case of pernicious anemia. This was all that you were telling me in terms of biochemical finding. Diagnosis ban gaya. I know it's a case of megaloblastic, pakka se. But now I need to know the cause of megaloblastic anemia. What is the cause? What are the different causes of megaloblastic anemia that I taught all of you? The different causes of megaloblastic anemia include either it could be a problem in the GIT or a problem in the ileum or a problem in the pancreas or it could be some infection. How will I get to know the cause of megaloblastic anemia? That is via a test called Schilling test. So please note, Schilling test is not for the diagnosis of megaloblastic anemia. For the diagnosis of megaloblastic anemia, I already have many other biochemical tests that I've told you. Itna acha table we made. Diagnosis of megaloblastic anemia has been made. This is done to know the cause of megaloblastic anemia, whether it is a pancreatic problem or an ileal problem or an infectious problem. But nowadays, no one does it. Schilling's test, you don't have to get into so much of details of its procedure because no one does the Schilling test. You can pass through it. Itna pata hona chahiye, this much you should know that it is one of the causes to get to know the cause of megaloblastic anemia, not for the diagnosis of megaloblastic anemia. All said and done, the last aspect, talking only and only about vitamin B12. What about the folate metabolism and deficiency? So please note, folate mein, what is the site of folate absorption? Folate absorption ka site is going to be the jejunum. The site of folate absorption is jejunum and the chromosome that controls all of this is chromosome 21 that controls the entire folate metabolism. Deficiency of folate metabolism is seen in alcoholics and in pregnancy, and you know that pregnancy may, not always, but if pregnancy may deficiency is seen, it can result in neural tube defects. That is why, do you give folate supplementation in the beginning? Yes, you do. So firstly, deficiency can be seen in alcoholics. Deficiency, if seen in pregnancy, can result in neural tube defects. Clinical features are similar to vitamin B12, but what will not be seen? Neurological manifestations will not be seen. Neurological signs and symptoms are only and only seen with B12 deficiency. What will be the serum folate? Of course, a folate deficiency hai, so serum folate will be less, red cell folate will be less. Red cell folate is a better marker. Remember, serum and red cell folate both will be less. And there is a test that shall be positive known as the FIGLU test. What is FIGLU? Pehle to I'll give you the ratta mnemonic. FIGLU test means that F for folic acid, U for urine. This is a urine test for folic acid deficiency. Simple. Folic acid deficiency ke liye urine test. But what is a FIGLU test? Please note, I'll tell you the basics. I think everyone knows from your biochemistry that histidine changes to first something known as FIGLU, form aminoglutamic acid, and then changes to glutamate. So when histidine has to change to glutamate, in between it makes form aminoglutamic acid, FIGLU, and FIGLU then uses folic acid to convert to glutamate. But now I'm saying that folic acid to nahi hai. Histidine se FIGLU bana, but after that the process did not go forward because Folic acid was not there. Where will all this fig glue go? The fig glue will come out into the urine. That is exactly what I told you. What is the fig glue test? The fig glue test is basically a urine test, and it is a urine test which is done to know which deficiency. It is done for analyzing the folic acid deficiency. So now you don't have to know anything more about it. It is nothing but the folic acid deficiency ke liye a urine test that we do. Very, very important about folate metabolism. Treatment, of course, you know, is vitamin B12 and folate supplementation. So nothing fancy about that. And on that note, we have finished off our discussion of macrocytic anemias. Yes, done. What are we moving on to next? The hemolytic